Myself, Dr. Suhahani. I'm Senior Resident of Department of Radiodiagnosis in Malabar Medical College. So today, I'll be talking about role of ultrasound in early pregnancy. So as we all know, ultrasound is the primary imaging modality in pregnancy. So in early pregnancy, the aims of doing ultrasound is first and foremost the localization of the pregnancy, whether the pregnancy is intrauterine or extrauterine. And next is the number of pregnancy, whether it is a singleton pregnancy or a multiple pregnancy. And third is the assessment of gestational age, by which we can calculate the growth of the pregnancy and also the expected date of delivery. And fourth, we can calculate we can look for the viability of the pregnancy. And last, we can look for the other maternal factors, the cervical length, whether any adnexal cyst are present, any intrauterine lesion like fibroid is present, etc. So in pregnancy, how we will do the early first trimester ultrasound? For that, we can use two types of probe. The one, we can use this curvilinear probe, which is of 3 to 7 megahertz frequency. It's for the transabdominal scan, and also we can use the transvaginal endoluminal probe, which is the transvaginal probe, which has a higher frequency of approx 5 to 10 megahertz, and we can also use a non-latex cover while using an endoluminal probe. So in pregnancy, we have in early pregnancy we can do two types of scan, either a transabdominal scan or a transvaginal scan. Transabdominal scan we have to do with a full bladder, whereas in very early pregnancy the structures won't be that much clear by a transabdominal scan, especially when the gestational age is too low. So in that cases we will do a transvaginal scan. For transvaginal scan we need an empty bladder. So approach, we will go in detail about the approach of the early first trimester scan. First, we have to localize the pregnancy, whether it is an intrauterine pregnancy or extrauterine pregnancy. Ideally, the pregnancy should be implanted in the upper part of the endometrium. And in intrauterine pregnancy also, there can be ectopic locations like lower endometrial implantation or cervical implantation or scar implantation, especially when the patient has a history of previous cesarean scar. And if we have a UPT positive patient with no intrauterine pregnancy, we should look for presence of gestation sac in ectopic location, most commonly in adnexa. Now, the first sign of pregnancy will be the presence of gestational sac. So, the gestational sac, we will identify the true gestational sac by the presence of something called double decidual rim sign. So the double decidual rim sign means the gestational sac will be surrounded by two echogenic lines. The inner echogenic line will be the decidua capsularis and the outer echogenic line will be the decidua parietalis. So a true gestational sac will be round shape, will be eccentric in location within the endometrial complex, and it will be surrounded by this two echogenic rim, that is the double decidual sign. Knowing this is very important because there is something called a pseudo gestational sac. Pseudo gestational sac is just a fluid collection within the endometrial cavity. We can see pseudo gestation sac in case of ectopic gestations due to the presence of fluid or blood in the endometrial cavity. So, how to differentiate between true gestational sac and pseudo sac is important. The true gestational sac will have a double decidual rim sign, whereas the pseudo sac will be having a single echogenic rim only. The true sac will be eccentric in location, it will be round in shape, it won't change its shape by after probe maneuver, and it also will have peripheral vascularity and on color Doppler. The pseudo sac, it is irregular shaped fluid collection surrounded by a single echogenic rim. It will be centrally located in the cavity, and the shape of this fluid collection may change according to the probe maneuver, and it won't have any kind of internal or peripheral vascularity on color Doppler. So after localizing the pregnancy, the next important thing is the number of the pregnancy. How many sacs are there, how many fetus are there, and how many placenta is there. The details of the multiple pregnancy we will be discussing in the coming slides. The third is confirming the viability. We can say a fetus is viable once we confirm the heartbeat. Once we see the cardiac activity, only we can confirm that the fetus is viable. Ideally, in the first trimester, we use M mode to detect cardiac activity, as there are certain bioeffects for the Doppler. When we use the M mode, we will get a sinus rhythm of the sinus rhythm for the cardiac activity, and from this we can calculate the heart rate either by measuring from a valley to valley or from top to top. And the next aim is to assess the growth of the pregnancy. In very early pregnancy, before we see the embryo, we will calculate the gestational age of the pregnancy by calculating the mean sac diameter. In late first trimester, we can use the crown rump length up to 13 weeks. So, and last, we will assess the other maternal factors also. What is the length of the cervix? The length of the cervix we will measure from internal os to external os. The ideal length should be more than 3 centimeter. And also we can look for placental location, any presence of retroplacental bleed or placental lesions. And also we can look for other pelvic structures, ovary, fallopian tube, etc. Now coming to signs of intrauterine pregnancy. The first sonographic sign of pregnancy is gestational sac. On transvaginal scan, we can see gestational sac by 4 to 5 weeks. Here gestational sac, as I told, it will be a round anechoic structure which is surrounded by decidualized endometrium. There will be 2 echogenic rim surrounding that. And the second sonographic sign of pregnancy is the yolk sac. Yolk sac is the first structure to appear within the gestation sac. Here we can see there is a gestation sac and there is a anechoic structure within the gestation sac. This we will see on transvaginal scan by 5 to 5.5 weeks. The size of the yolk sac should be ideally less than 6 millimeter. And the size of the yolk sac we have to measure from inner to inner diameter. The outer rim we shouldn't include. And the size of the yolk sac more than 6 millimeter, it is suspicious of early pregnancy failure. And now the next thing to appear is the fetal pole. First gestation sac, then yolk sac, then fetal pole. It is seen on transvaginal scan at 6 to 6.5 weeks. It first appears as a dot on the side of the yolk sac. This appearance is called diamond ring sign, where the yolk sac forms the rim and the embryo forms the diamond. This stage is yolk sac embryo complex. From this stage, as the gestation advances, this embryo will change its shape from this rim to a rice grain size, and towards the end of the first trimester, it will be kidney bean shaped shape. And the next thing to appear is the cardiac activity. First, it will appear as a subtle flicker, and as I told earlier, we can measure the cardiac activity using M mode. The next thing to appear is the amnion. Amnion is a thin membrane which is surrounding the embryo. It will appear close to 7 weeks. So once the amnion appears, it will surround the embryo, and the yolk sac will be lying in the chorionic cavity, and amnion will be covering the embryo. So yolk sac will be yolk sac will be there in the chorionic cavity, and embryo will be there in the amniotic cavity. So the order of appearance in brief: first thing to appear is gestation sac by 4 to 5 weeks, then yolk sac or at 5 to 5.5 weeks, fetal pole at 6 to 6.5 weeks, cardiac activity, and last is amnion, which will appear near to 7 weeks. So next is how we will calculate the gestational age, the measurements which we take. In early first trimester, that is before the appearance of embryo, we use the mean sac diameter. For calculating mean sac diameter, we have to take 3 dimensions of the gestational sac. The outer echogenic rim we shouldn't include. We will calculate the anteroposterior, transverse and craniocaudal dimension of the mean sac diameter, and using that we will calculate the gestational age. Now almost all the ultrasound machine have the automatic ability to calculate the gestational age once we calculate this mean sac diameter. And in late first trimester. Once the fetal polyps appear, we use the crown rump length to calculate the gestational age. The CRL or the crown rump length is mainly used from 6 to 13 week. For that, we need a mid-sagittal view, and the longest straight dimension from the head to the bottom we use to calculate CRL. We shouldn't include the extremities, and the embryo shouldn't be much flexed. If it is flexed, we will underestimate the gestational age. And this we can use till 13 week. After 13 week of gestational age, we will use biparietal diameter, head circumference, etc. to calculate the gestational age. Now coming to multiple gestation, as we know, there are different kind of multiple gestation. In twin pregnancy itself, there are dichorionic, diamniotic, monochorionic, diamniotic, monochorionic, monoamniotic, and conjoined twins. The chorionicity and the amnionicity is best identified in the first trimester. As the pregnancy advances, it will be difficult to identify the chorionicity and amnionicity. Now first coming to the first one, dichorionic, diamniotic twins. In DCDA twins, we know we will see two separate gestational sac, and there will be a thick membrane of chorion which is extending between these two gestational sac. This thick membrane of chorion is called a lambda sign, and also we will see separate placental masses. As the pregnancy advances, this placental masses will abut each other, and it will be difficult to differentiate whether it is a single placental mass or different placental mass. So it is better appreciated in the first trimester. So in DCDA, it is mainly two different gestation sac which is separated by a thick chorionic membrane giving lambda sign. Now coming to monochorionic diamniotic twins, in that there will be a single gestation sac but two different yolk sac which is separated by a thin intertwin membrane giving T sign. Lambda sign is in DCDA. In MCDA twin, we will get a thin intertwin membrane giving T sign. In MCDA twins, we will get only a single placental mass. Coming to monochorionic, monoamniotic twins, there won't be any different sac, there won't be any intertwin membrane. Only one yolk sac will be seen. In the later pregnancy, there are more chance of entangled cords. Now coming to molar pregnancy. Molar pregnancy is also we should pick up in the first trimester scan. Molar pregnancy are two types, partial hydatidiform mole or completed hydatidiform mole. So the complete absence of fetal tissue, it is more in favor of complete hydatidiform mole. Presence of any fetal parts is in favor of partial hydatidiform mole. In complete mole, it is diploid phenotype. That is, the complete chromosome set will be derived from the paternal sperm. In this, we won't see any intrauterine fetus. It will be a complete intrauterine mass with multiple cystic areas, which is giving a snowstorm or bunch of grape appearance. In this on ultrasound, we can look in bilateral ovaries. Bilateral theca lutein cysts may also be present. Coming to partial hydatidiform mole, that is the fertilization of ovum by two different sperm, and the genotype will be 69 XXY or XXX. In that, we will see enlarged placenta with a part of it showing cystic areas. It may be associated with a gestation sac which is showing a amorphous fetus or a fetus which may go to intrauterine fetal death. Here we can see there is a gestation sac with a fetus. Here the placenta also we can see a part of the placenta is showing multiple cystic areas within. So because of the presence of fetus, this is a partial hydatidiform mole. So the in partial hydatidiform mole, mostly the patient will go to intrauterine fetal demise. Now the next thing is ectopic pregnancy. When should we suspect ectopic pregnancy? When we have a patient with positive pregnancy test and we are not seeing any sign of pregnancy in the uterine cavity. In that, we should look in the other ectopic location to see for the presence of any gestational sac. So the most common location is the fallopian tube. And the most common sign is the tubal rim sign, that we will see a echogenic structure in the adnexa which is surrounded by a anechoic structure in the adnexa which is surrounded by an echogenic rim. And here we can see the uterus, the cavity is empty, and in adnexa there is a sac which is surrounded by echogenic rim, that is a tubal rim sign. The ectopic here also we can see over here, this is the left ovary. Near to that, we can see a sac with a tubal rim. This was a case of tubal ectopic pregnancy. So, this ectopic pregnancy also shows increased peripheral vascularity, and once it ruptures, there can be associated hemoperitoneum. That is the presence of, mostly on USG, we will see the presence of fluid with echoes in the pouch of Douglas. Now, another thing that we should look in the first trimester scan is presence of subchorionic hemorrhage. It will be seen as a crescentric collection which elevates the chorionic membrane. So, depending on the time of the bleed, depending on how much the time has elapsed after the bleed, the presence of the appearance of this bleed can change. Once it is very acute stage, it will be hyperechoic or isoechoic to chorion. That is, it will be more white. As the time passes, it will become more hypoechoic. That is, it will become more black in subacute and chronic stages. So, the quantification of subchorionic hemorrhage is very important. How much it encircles the gestational sac, that is a predictor of prognosis. So, to say it is a small subchorionic hemorrhage, it should encircle less than 20% of the sac, and medium sizes, once it encircles 20 to 50% of the sac, and once it encircles more than 50% of the sac, we take it as large size subchorionic hemorrhage. So, large hematoma, that is once it is more than 50 cc or it encircles more than 50% of sac, it worsens the patient prognosis. Here we can see there is a gestational sac, and here towards the lower pole of the gestational sac, we can see this hypoechoic collection which elevates the chorionic membrane. And this was case of subchorionic hemorrhage, and here it encircles less than 20% of the sac only. So, it is a case of small size subchorionic hemorrhage. Now, coming to diagnosis of early pregnancy failure. There are certain findings which are diagnostic of early pregnancy failure and which are suspicious of early pregnancy failure. Findings diagnostic of early pregnancy failure are, we are seeing crown drum length more than 7 mm, but still we are not seeing any heartbeat on transvaginal scan, or the mean sac diameter more than 25 mm without an embryo. And next is embryo irrespective of CRL without cardiac activity on initial scan, and in that case we shall follow up after 7 days, and still if we are not seeing any cardiac activity, it is early pregnancy failure. Or other sign is cessation of previously documented cardiac activity. And the last two conditions are absence of embryo with heartbeat more than 2 weeks after a scan that showed a gestational sac without a yolk sac. And also, if we are not seeing any embryo with heartbeat after 11 days after a scan that showed a gestation sac with a yolk sac. These are criteria for diagnosis of early pregnancy failure. There are certain conditions which we say as findings suspicious of early pregnancy failure. That is when its CRL is less than 7 mm without a heartbeat, mean sac diameter is 16 to 24 mm without a heartbeat, absence of embryo with heartbeat 7 to 13 days after a scan that showed a gestational sac without yolk sac, absence of embryo with heartbeat 7 to 10 days after a scan that showed a gestational sac with a yolk sac, or absence of embryo more than 6 weeks from the last menstrual period, and enlarged yolk sac, that is more than 7 mm inner to inner diameter. Ideal yolk sac should be less than 6 mm. So, overall in summary, the main role of ultrasound in early gestation is first to localize the pregnancy and to look for the viability of the pregnancy, to calculation of the gestational age, and to look for other maternal factors which may complicate the pregnancy, like fibroid complicating pregnancy, etc. Thank you.